Hey everybody, welcome to Spot Check here. This is going to be a video here to help kind of break down some diseases of cornification for derm residents, medical students that are interested, maybe some recertifying dermatologists or other practitioners that are interested in the field. It is challenging. There's a lot going on here, a lot of different cases, a lot of different disease states, and a lot of overlap, but hopefully hearing this on repetition will help get this through. Here in front of you, we got 3 awesome medical students that this couldn't have been possible without. So drop them a like, let them know in the comment section how great they are and give them a thank you, okay? Right here, all the disease we're going to talk about. It's going to be a long one. Buckle up. We'll review as we go through. But here's the list for us today. Start out here with Ichthyosis vulgaris. So we have fine scaling distributed on the trunk and extremities. It spares mostly flexures in the face. You'll see this often on the legs. It's associated with KP. It's associated with atopic dermatitis. So you're going to see some findings that are suggestive of that. One of those being hyperlinear palms. Ultimately here, just giving moisturization, making sure that we keep the skin barrier moist. Adding a cherolytic agent, lactic acid's good to help maybe exfoliate some of that scale off. Ultimately, it's considered an autosomal dominant mutation in the filaggrin gene, FLG. And what we can talk about here a little bit is filaggrin. So filaggrin's made in the keratohyalin granules in the stratum granulosum. And that's kind of where part of the cornified envelope starts, at least its function or its building. You have profilaggrin in these keratohyalin granules that are then released into filaggrin, and that's usually as the stratum granulosum layer approaches the stratum corneum junction. Then when filaggrin is released, that helps form in part the cornified envelope. Filaggrin then also breaks down to urocanic acid, which is a natural UV blocker, as well as a natural moisturizer. And that kind of in part makes sense, given the disease state here. If you wanted it's often a clinical diagnosis, but if you wanted the biopsy, you can, and what you'd see here is that the granulosa layer is diminished to a degree. You'd see some hyperkeratosis, orthokeratotic hyperkeratosis, and you could do a filaggrin stain, which you'd notice would be negative, but often is a clinical diagnosis. Moving on, we have steroid sulfatase deficiency or X-linked ichthyosis. So X-linked ichthyosis has brown, darker adherent scales in the lower extremities. Some would argue a little more severe. They're usually larger. They spare the face, palms, and soles. And scalp scaling might be present. Now, the key thing here is the associations with X-linked ichthyosis. That's eyes, gyne, and GU associations. And these are pretty important. This is often what's tested. Eyes, you'd see corneal opacities, and they're often described as comma-shaped. OB, even though this is the X-linked disease, as you can tell by the name, there are female carriers, and female carriers can have placental sulfatase deficiency, prolonging labor and maybe causing C-sections. Okay. Other concerns in GU category for males, cryptorchidism and testicular cancer. And even if you get the cryptorchidism repaired, those men still have an increased chance of testicular cancer, even after cryptorchidism repair. That's a key takeaway here. Similar pathway of treatment here. You can add retinoids more to this one because the scale is thicker and probably more bothersome, so you can exfoliate it with retinoids as well. Ultimately, it's X-linked recessive. The steroid sulfatase genes on XP2223, and this actually is important because you can have this form into like a contiguous gene syndrome, and this can down the line form into or overlap with something called Kallman syndrome, which is located very close to this gene on the X chromosome. Incidence, labeled here, not too important to know, but it is somewhat common, compared to other diseases that we'll talk about today. You'll have a reduction or deletion of the steroid sulfatase gene. This affects cholesterol sulfate pathway, and as you know, cholesterol is a part of the steroid synthesis pathway as well. So you'll notice that DHEAs hydrolysis is affected as well, and you might have an increase in that byproduct. Now, how do we diagnose this? We can diagnose this with amniocentesis. So you can do a steroid sulfatase assay, or you can look for increased DHEAS. In urine, you might find those non-hydroxylated DHEASs as well as estriol. And then we're moving more towards microarrays, PCR analysis, FISH, which help identify deletions better, but those other options are available up top. Elevated cholesterol sulfate levels are, often found as well, and you can even see increased LDL mobility. Alrighty, next disease on our list here to cover is epidermolytic hyperkeratosis. Now, you will see this under several different names. You'll see it under epidermolytic ichthyosis, bullous congenital ichthyosiform erythroderma, bullous ichthyosis. And some people categorize these slightly differently. Some people categorize them the same, but they all share one characteristic, and that is the pathological finding of epidermolytic hyperkeratosis. So, presentation in babies with these diseases. Other names you might see, like if you look at our review book, you might see epidermolytic ichthyosis more commonly. Occasionally, you'll see in old literature, I think bullous CIE, but so don't get it confused. And this is kind of where it gets a little confusing. But repetition's key here. But anyhow, presentation here, you're gonna have more erythema and hyperkeratotic denuded skin. There's going to be peeling, there's going to be erosion. It's a little more severe. In infancy, since you're having such severity, you're going to look out for electrolyte imbalance and sepsis. Treatment-wise, ideally protective isolation, and that helps prevent from sepsis. Topical lubricants. And in some literature, it's suggested that retinoids are exaggerative in this disease. So, what you'll hear time and time again as we go through is some of these diseases respond well to retinoids. But this one, it seems to be suggested that they are exaggerative. Now, as we get out of the infancy and into adulthood or childhood, you'll see that you have hyperkeratosis with ridging in the flexure spaces. And then in between those hyperkeratotic ridges, you'll have areas of erythema and like fresh skin, fragile base, which is pictured here on your left. You can also see a palmar plantar keratoderma, angular cheilitis, and occasionally some foul odor can be experienced with these children. Again, treatment, antibacterial soaps is pretty key here, as well as just topical emollients and humectants to help soften that scale. You'll notice that the disease here is autosomal dominant. Mutations are on keratin 1 and keratin 10, those are like mutations that are described. 50% of the cases are spontaneous mutations as compared to inherited. And what you'll know is that the keratins that are affected play a role in how the pathology presents. So keratin 1s and keratin 10 are keratins that are more expressed in the upper levels of the epidermis, so starting at the spinous layer, but more in the granulosus layer and above. So that's where you're starting to see some of the breakdown in the hyperkeratosis present, because that's where the dysfunction is. Prognosis here, you're going to have reduced blistering and peeling with age, as you saw in those pictures in the previous slide. Hyperkeratosis develops, unfortunately, and those are more of the typical things that you'll see as this disease progresses. Now, the epidermolytic hyperkeratosis, that is kind of the key part of this, and that's what's shared histologically, or the described histological finding. Skin biopsy will show clumped keratin filaments, and DNA analysis can be done if there is like a familial presence and you kind of have a suspicion. That can give you somewhat of a clue. Pathology-wise, you'll also see like cytolysis of the suprabasal layers and granule layers, hypergranulosis, orthokeratotic hyperkeratosis. Some other key things I have in my notes here. It's just tell you guys that if we see a keratin 10 mutation, specifically as compared to keratin 1, you might have some obvious sparing of the palms and soles, and that's because keratin 9 is the predominant keratin in the palms and soles as compared to keratin 10. So that's kind of a helpful clue if you ever have to pick exactly which, you know, mutation is out there in the unfortunate situation that you're in that. Also, in patients with epidermal nevi or many epidermal nevi, if you were to biopsy one of those epidermal nevi and it shows this pathological finding of epidermolytic hyperkeratosis, then you could argue they're a mosaic for this disease or one of these congenital diseases, and then that could, influence how you counsel a patient. So you can let them know, hey, we found this on your epidermal nevi, this pathology. This can suggest that if you have offspring, they might have a full-blown epidermolytic ichthyosis or bullous CIE or, one of these diseases, depending on if you're a lumper or a splitter. But that's just something to be aware of, too. It's a commonly tested question. All right, moving on, we have lamellar ichthyosis. So this one is one of the first diseases we'll talk about that produces a collodion baby. So that's going to be something that comes up recurrently as we go through some of these diseases. Collodion babies. Now, this is when you have a unique membrane at birth that then is shiny, kind of silvery, wet almost, and it then ends up being replaced by large scales. There's also generalized erythroderma and superficial fissuring. The scale then becomes very dark, as you can see in this picture on the left, and more accentuated in the flexures. Since you have a collodion baby, you have this significant scaling. You're going to have risk factors or associated features that include ectropium, echolabium, scarring alopecia, nail dystrophy, palmar plateau, plantar keratoderma, and heat intolerance. Ultimately, you're going to have to go through a treatment for the collodion baby. Oral retinoids can help, help with the scale and exfoliate that, as well as humectants and emollients are helpful in this case too. The disease mutation is in the transglutaminase 1 gene, TGM1. The concern here is that this mutation results in desquamation because you cannot appropriately form a cornified envelope through cross-linking. And that's what transglutaminase enzymes tend to do. Now, the key thing here is to memorize which transglutaminase enzyme is associated with which disease state. So, as you know from just listening to me, lamellar ichthyosis is associated with transglutaminase 1. There is a transglutaminase 3, which is a target, an antigenic target for dermatitis herpetiformis, DH. So that's kind of a key thing to get separated. Another disease state called acral peeling skin syndrome holds a mutation for transglutaminase 5. So being able to at least tease those out a little bit will be helpful in nailing the disease process. Alrighty, now let's move on to CIE, congenital ichthyosiform erythroderma. Other names you'll see for this: non-bolus CIE, erythrodermic autosomal recessive lamellar ichthyosis, ichthyosis congenita type 1. What's kind of helpful with some of those names is this, has some overlap with lamellar ichthyosis, which is nice. And that overlap starts right off the rip. We have a collodion baby. So collodion babies also, like I said, you'll see that a few times associated with certain syndromes. But you'll have a collodion baby. You'll also have white scaling and erythroderma distributed throughout the whole body. You'll see a keratoderma of the palms and soles. With the collodion baby and syndromes that are more severe, you're going to see ectropion, scarring alopecia, hypohidrosis, nail dystrophy. This disease is more unique in the sense that there's increased risk for basal cells and squamous cells reported. Of course, treatments, keratolytics for the scale, topical retinoids help reduce scaling as well. Does not improve the erythema though, which is kind of key, right? And you'll know that just based on the retinoid mechanism of action. Increased fluid and protein intake, because as you know, we're going to lose moisture, we're going to lose protein through just rebuilding the skin barrier, and it's going to be important to not be deficient in those. The inheritance of CIE, autosomal recessive. Now, there are quite a few genes implicated, but the key ones that are being tested now in terms of review books and what they're labeling is ALOX E3, ALOX 12B, and a little more rarely transglutaminase 1, which overlaps with the previous that we talked about, hence some of those sharing phenomena with lamellar ichthyosis. But I really want you to nail in your head ALOX E3, ALOX 12B. Okay? Histologically, we'll know that really the findings aren't too descriptive. You might see some increased lipid droplets in the stratum corneum. This disease does tend to improve with age, which is very helpful. All right, moving on. Now here we have a cornification disease that has a more severe presentation, and it's called Harlequin fetus. You have massive, diffuse hyperkeratotic plates, deep fissuring. It's all across, starts at birth on a newborn. Severe ectropions, obviously evident, as you can see in that picture on your left. Echolabium. This deforms the nose, fingers, eyes, toes. You can't regulate your temperature at all. You have an increased risk of sepsis. So things that are helpful, topical emollients, obviously, correction of the ectropion if you can, if they live long enough. Retinoids actually do improve survival in these patients, so it's important to kind of get those started early when you surmise the diagnosis. The disease is described with a few different in a few different ways, but mostly described as an autosomal recessive inheritance with the de novo deletion on this chromosome 18 in the region of Q21. It's a pretty rare disease, but it does happen, unfortunately. Ultimately, like, there's a few different mechanisms that are surmised, but you could have defective keratinization from a biochemical standpoint. It could be a lipid metabolism disease. It could be absent lamellar granules leading to, or defective profilagrin, both leading to a broken down cornified envelope. Prognosis is poor, but there are some patients that go to live on with a nice, healthy life, but prognosis still is guarded, and usually, death happens either from sepsis or respiration complications. Feeding complications also are implicated, but it's more likely sepsis or respiration. All right, moving on. We have Sjorgren Larsson syndrome here. Presentation, it changes, from infancy to approaching adulthood. So in infancy, you're going to have a generalized ichthyosis and erythroderma, fine areas of scaling, large lamellar scaling, hyperkeratosis, itch. But then as they get older, the scale becomes darker without erythema, accentuated in the flexures, lower abdomen, and backsides of the neck. It spares the central face. Another key with Sjorgren Larsson is the associated features. Just like how we talked about with steroid sulfatase deficiency, Sjorgren Larsson has some associated features with it as well. In terms of these associated features, CNS features include mental retardation. A scissor gait is described, speech deficits, epilepsy, in terms of just the CNS. But now the eyes also have a set of findings, and that includes atypical retinal pigment degeneration in the macula and some retinal pigmentary changes as well. With this comes photophobia. Treatment options for this disease, again, very similar to the previous. Emollients or retinoids help. They're also going to need followed by specialists beyond dermatology. This also is a disease that can present as a collodion baby. So keep that in the back of your head. Add that to lamellar ichthyosis. Add that to CIE. Also a collodion baby disease. One interesting thing here to note is that xyluton, can be helpful in reducing leukoB4 synthesis, and that helps with pruritus. And that plays a little bit into the mechanism here that we'll talk about. Ultimately, what you'll note is that it's an autosomal recessive disease. The gene is on the FALDH gene. That's 17p11.2. Rare. It's a rare disease, but still relevant. 50 mutations in the FALDH gene that have been identified, and this results in decrease in fatty alcohol, NAD oxidoreductase activity. Prognosis is purely dependent on the CNS findings and the ocular findings. What you'll see with here is that we have a fatty mechanism breakdown, so you're going to see fatty accumulation in certain granular cells, so neutrophils, eosinophils, mast cells will all show some lipid droplets, which are noted here on the left. You can see that also with amniocentesis, you can identify maybe the gene that is dysfunctional. Fetal skin biopsy sometimes can help, but not so much recommended anymore. Often DNA genetic testing will get you an answer in today's day and age. All right, moving on, we have Refsum syndrome here. Ultimately, Refsum will have a mild ichthyosis. That's usually at the beginning, before you have any neurologic symptomatology. Now, the associated findings here are what's more important for Refsum syndrome as compared to the skin findings. The skin findings seem to maybe signal the inevitable CNS, eyes, ENT, etc. So let's break these down. In terms of CNS findings, you can have cerebellar ataxia, progressive peripheral polyneuropathy. In the eyes, you can have retinitis pigmentosa with salt and pepper pigment. And the salt and pepper pigment seems to be what's, possibly tested on here. It's kind of a buzzword in a way. ENT, you can have sensory neural deafness. Cardiac can contain arrhythmias with heart block and maybe even cardiac failure in severe cases. You can also have MSK symptoms such as muscular wasting. The key here, and it's based on the mechanism of the mutation, the key here is reducing phytanic acid in the diet. So phytanic acid you can find in heavy green vegetable diets, dairy products, and ruminant fats. In severe cases, you can try to do a plasma exchange of phytanic acid and get symptom improvement that way. The disease is autosomal recessive. The disease is with the PAHX gene on chromosome 10 or the PEX7 gene on chromosome 6. Rarely reported, but still relevant. Mutations in specifically PAX create a deficiency in phytanyl-CoA hydroxylase, which leads to accumulation of phytanic acid, hence the concerns that we brought up in the last PowerPoint slide. You can also have mutations in the PEX7, which is like a peroxisomal enzyme deficiency. The prognosis depends solely on how early can we do intervention and exchange processes, and if we can further prevent destruction of like the CNS, heart, and lungs, etc. Diagnosis, of course, DNA analysis is kind of the evolving future of these diseases, but amniocentesis has also been used for doing a phytanic acid oxidase assay. You will often see increased serum phytanic acid. Skin biopsy can have lipid vacuoles as well in the keratinocytes, and increased cerebrospinal fluid protein without cells. Alrighty, the next disease we're going to talk about is Conradi-Humerman-Happel syndrome, also known as X-linked dominant chondrodysplasia punctata. Now, that's going to overlap a little bit with the next disease we're going to talk about, so there's going to be some key features we're going to have to nail between the two. But this presentation is erythroderma at birth with fixed scale, hyperkeratosis in the lines of Blaschko. Then as they grow older, the erythroderma resolves. There then forms an atrophoderma, sometimes in the lines of Blaschko, but sometimes mainly on the forearms and hands, as well as hypokeratosis in the lines of Blaschko as well. You'll have several associated features which are often tested with this disease, and that includes scarring alopecia, but more notably bone features such as frontal bossing, stippled epiphyses, which we'll notice only during infancy, premature calcification, and asymmetric limb shortening and scoliosis, and that's what's going to be, compared and contrasted to the next disease. So keep this in the back of your head. You'll also see eye deficits described as asymmetric cataracts. So you'll have a cataract maybe in one eye or the other. Treatment for this, we're going to have to do emollients, keratolytic agents, but given the eye findings, given the bone findings, this patient will need ultimately further specialist workup. It is an X-linked dominant mutation in the EBP gene. It occurs mostly in women and children because it happens to kill males in utero. There is deficits in the cholesterol biosynthesis pathway, and that's all, obviously resulting from the EBP gene mutation. Diagnosis, you can do an ultrasound to evaluate the long bones. Ultimately, this improves with age. There's a few other diseases that can overlap with this, noted here. The most notable being child syndrome. Child syndrome also stands for congenital hemidysplasia with ichthyosiform erythroderma and limb defects. So child. Presentation is the unilateral erythroderma, and the key here is unilateral. So Cornification syndrome is a generalized erythroderma, but child syndrome is a unilateral erythroderma with very defining midline borders. Associated features with this include ipsilateral alopecia, nail dystrophy, ipsilateral limb hypoplasia, and you'll have true hypoplasia of the limb where Cornification might have just more skeletal defects. Usually child has more severe presentations, according to some of our review textbooks in dermatology. You'll also see organ hypoplasia, and that's usually ipsilateral. So you could see CNS, CV, renal, or GI hypoplasia, depending on the affected areas. Treatment here, topical or systemic retinoids, of course, for the skin manifestation. They'll have to be inevitably follow up with specialists given the associated features above and what may or may not be affected. Here, pathology, you'll see a thickened keratin and stratum spinosum layer with parakeratosis. You'll also see the sweat glands are surrounded by a granular layer, and there would be histiocytes in the dermal papillae. X-linked dominant mutation, and this is in the NSDHL gene, lethal in males, like we talked about. This also is a defect in the cholesterol biosynthesis pathway, results obviously from the mutation of the NSDHL. You can do an ultrasound of organ and limbs to determine deficits. Prognosis is variable, given on what's affected and severity. Now, if you look on the left here, this is a great example of that unilateral manifestation in erythroderma, as well as not overtly noticeable, but some asymmetry between limbs. And I implore you, honestly, to kind of find ways to sink this into your head, whether it's like a funny little story or, maybe you have maybe you do like a picture palace type thing where you create pictures in your head. Those really help kind of nail down these disease states. I have some for these. I'm sure you'll come up with some as you go through these as well. But that really helps. So like an example for this one, just to kind of get a idea of what's going on. So I picture like a DHL, like the packing company, the shipping company, putting a child into a box, and they seal the box with a tape on the box shaped like an X, and they put it in the back of the DHL truck, and the truck has its tires blown out on one side. And that kind of helps me get some of, if not most of the pieces of this disease state. Now, I have a few others. It's up to you guys whether or not you want me to start interjecting them or if you have your own, because I don't want to confuse you guys. But that's something to think about. And if you have ones that are super interesting that you want to share, put them down in the comments below. Let us know, and we can learn off each other that way as well. All right, now that we kind of finished child syndrome, let's just do a review of the left side column here briefly. So what you'll know here, let's go with ichthyosis vulgaris. We know it's a most likely autosomal dominant mutation in the filaggrin gene. You get some scales usually on the lower legs, and treatment's benign. It's a common mutation. It's associated with atopic derm. It's associated with filaggrin. It's associated with KP as well. You have X-linked ichthyosis. Other name for this is steroid sulfatase deficiency. That one, you'll need to know some of the other findings, and that includes that it could be a contiguous gene syndrome with Kallman syndrome. It could also, have GU abnormalities such as cryptorchidism, testicular cancer. It can also present with C-sections because you have a prolonged delivery in female carriers. Also, you'll have corneal opacities with this disease as well, and they're described as comma shaped. If we need some buzzwords here to help get us through. Alrighty, epidermolytic hyperkeratosis. Many names associated with this: epidermolytic ichthyosis, bullous CIE, and epidermolytic hyperkeratosis is kind of the histological finding here. Keratin 1 and 10 are often implicated. This one might exacerbate if you use retinoids. This one usually presents as a generalized like erythroderma, but then changes into a hyperkeratosis scale in the flexures that shed and leave areas of nice healthy pink tissue. Some foul odor can be associated with this one. Pathology findings I think are important for this one, so let's go through those. That's orthokeratotic hyperkeratosis, that's hypergranulosis, and cytolysis of the suprabasilar and granular layers. Next would be lamellar ichthyosis here. One of the first diseases we talked about that produce a collodion baby. So you'll have erythroderma, you'll have some of the collodion baby features here: ectropion, echolabium, scarring alopecia, nail dystrophy, palmar plantar keratoderma is associated with this. Heat intolerance is associated with this. The key here is knowing the mutation also, which is the transglutaminase 1 protein, or the gene TGM1. Also being able to differentiate that from TG3 association in DH and TG5 association in acral peeling skin syndrome. We can then talk about CIE here. CIE is another cause of collodion baby. It's also cited, and I don't know if I talked about this, but it's also cited as the most common cause of collodion baby statistically. Same features we talked about. This one is, and this one and the last are both benefit with topical retinoids to a degree. The mutations in this one that are most important is ALOX12B and ALOXE3, and more rarely TGM1. We can then talk about Harlequin fetus. This is that severe picture that you saw on the left side of the slide. Severe picture: massive hyperkeratotic plates, deep fissuring encasing a newborn, severe echotropion, severe echolabion, poor temperature regulation, sepsis, often die from sepsis or respiratory compromise. The Harlequin fetus, again, is autosomal recessive, and it is implicated that it is the ABCA12 gene mutation, and this is a transporter of lipids, a lipid transport protein. Sjorgren Larsson. This has the two stages, another collodion baby also. So there's an infancy stage where you have generalized ichthyosis and erythroderma, and then this progresses to a darker scale without erythema as they get older. Sparing the face. This has associations of CNS abnormalities as well as eyes, so the retinal pigment degeneration in the macula, and then CNS abnormalities to elaborate the spastic ditetraplegia and scissor gait. This one also amendable to topical emollients, retinoids. Xyluton also seems to be very beneficial. The mutation is in the FALDH gene. Refsum here. Refsum, we talked about mild ichthyosis, but lots of overlapping associated features, and that includes a cerebellar ataxia, retinitis pigmentosa, sensory neural deafness, arrhythmias with heart block, cardiac failure. Also noting the retinitis pigmentosa buzzword here is salt and pepper pigment. Disease mutation is autosomal recessive with the PAHX gene or PAX gene, and that involves the phytanic acid production or processing. And then you have an accumulation of phytanic acid being found in vegetables, dairy, and ruminant fats. We have Conradi-Humerman syndrome, X-linked chondrodysplasia punctata. That has a generalized erythroderma with hyperkeratosis in the lines of Blaschkow, which then, as the child or patient grows up, the erythroderma resolves. Atrophoderma might take over areas, as well as hypo or hyperkeratosis that is either retained or lessened in the lines of Blaschkow. You'll also see some associated features. In this one, you'll see premature calcifications, frontal bossing, asymmetric limb shortening, asymmetric cataracts. And due to these kind of overlapping features, the cataracts and the skeletal abnormalities, there will need to be orthopedic and ophthalmologic evaluation. And then lastly, we have I also didn't say that it is an X-linked dominant mutation in the EBP gene, leading to defects in the cholesterol biosynthesis pathway. And then lastly, we have child syndrome, unilateral erythroderma, and that's the key here compared to the previous. This is a unilateral, sharply demarcated, and there's usually a nice border on the midline. Presents also with ipsilateral alopecia, nail dystrophy, ipsilateral limb hypoplasia, and organ hypoplasia. So you can have effects of the CNS, cardiovascular system, renal, or GI disease as well, depending on the ipsilateral findings. Mutation here is the NSDHL gene. It is X-linked dominant. It is typically lethal in males. All right. We did it. We're doing great. We got another half of this to get through. Buckle up. All right, time to keep on keeping on here. We have Netherton syndrome, and the presentation evolves. Initially, you'll have a generalized erythema and scaling, and then later you'll get migratory erythematous polycyclics or pigeonous plaques, and that's what you'll see here on the left. There's double-edged scale that's noted in here. You can also see atopic derm and seborrhea-like scale. Treatment here, retinoids, and here, so Netherton, I think of never place, like Netherton overlaps or rhymes kind of with never, and this is where I remember to avoid keratolytics and, more importantly, avoid tacrolimus. So with this compromised skin barrier, the severity of it, tacrolimus is more readily absorbed, and that increases risk of toxicities as well. There's also associations with increased allergic findings as well. You might even see increased or hyper IgE to a degree, increased levels of IgE. So sometimes you'll want to refer to allergist for RAS testing. The mutation is in the SPINK5 gene, and it's a rare finding. The SPINK5 gene encoding LECT1. LECT1 is also associated with atopy, which is why you see some overlap with atopic derm and allergies. You could have partial remissions and may have complete improvement at puberty, but ultimately a normal lifespan once you get through the infant years. Some other findings that are important, you can do a DNA mutation analysis, which obviously is the way of the future and how we're kind of presenting these now. Increased IgE might be found, as we talked about, and that's why we do the RAS testing. Pathology here, you're going to have trichorhexis invaginata, and that's pictured on the left, where the hair shaft actually takes on like a bamboo-like appearance, ball and socket type appearance. Next disease we're going to talk about is, I often abbreviate as EKV because sounding things out is very difficult for me, but the disease is erythrokeratoderma variabilis, and you have kind of two sets of findings here. You'll have well demarcated geographic patches of erythema that change from shape and position day to day. Increased propensity on the face, buttocks, and extensors. You'll also have fixed focal hyperkeratotic plaques. These ones don't change as rapidly. They can be generalized, but also palms and soles will be involved as well. You can see these, those geographic patches of erythema change day to day, and that could be the cold, the heat, the wind, emotional state. Treatment, ultimately you can do retinoids or topical keratolytics with emollients for the plaques mostly. Depending on the severity, you can also consider an oral retinoid. and that could get you a decent response as well. The disease here is a mutation in the GJB3 genes and GJB4 genes. Those are both implicated. These genes encode connexin, which connexins make up gap junctions. So connexin 31 and 30.3 respectively. And we'll have defects in these gap junctions, which then inhibit epidermal differentiation and limit an appropriate skin response to an external stimulus. Ultimately, there's kind of a period where it gets worse early in life, and then around puberty it tends to stable out a little bit. But also, you'll have a normal lifespan, and your general health will be relatively fine. This is mostly a cutaneous condition. Don't forget about your Genoderm when you see something like this. Don't forget to rule out psoriasis, parapsoriasis, other diseases that are a little more common than some of these Genoderms. Mutations are often what we target for diagnosis, so DNA analysis of the GJB3 and GJB4 mutations. Pathology, I have it listed out here. You're going to see orthokeratotic vascular weave hyperkeratosis, maybe severe acanthosis, a prominent granular layer, severe papillomatosis, depending in the findings in the area, suprapapillary thinning. But ultimately, you're able to kind of help treat this, mitigate the process, and hopefully it stabilizes as they get older. Kid is a good syndrome because it helps tell you what's in the syndrome. It's like child syndrome. So kid is keratitis, ichthyosis, deafness syndrome. So it presents with just that. Hyperkeratosis for your ichthyosis, and that includes follicular plugging and erythema. The keratotic plaques can be found on the extremities, face, and trunk. There can also be a palmar plantar keratoderma with stippled surface. You also have the keratitis, so I'll skip to the eyes section of the associated features. You'll have progressive bilateral vascularized keratitis, and this can eventually lead to blindness if not, ideally or astutely managed. And then deafness, you can have non-progressive sensorineural deafness. Now, given the degree of ichthyosis, you can also have dystrophic nails and hair alopecia as well. But the key thing is also recognizing the ENT and the eye findings. Treatments, much the same. You can do for maybe secondary infection, antibiotics, systemic antifungals. More importantly, the topical emollients and the keratolytics. Oral retinoids, though, I would use with caution because of the concomitant keratitis, and this could potentially exacerbate that. Mutations, autosomal dominant, and there's been a recessive transmission reported as well, but the implicated gene mostly is the GJB2 gene, which is another connexin encoding gene. This encodes for connexin 26, and that is another gap junction protein that's responsible for intracellular communications in the epidermis, but also responsible for intracellular communications in the cochlea, which is why you have the deafness findings. Your prognosis is dependent on, obviously, your eye and ear findings to a degree, but if those are managed and minimized to an extent, then you have the chance of a nice, healthy, normal life. Diagnosis here, we talked about some prenatally. You can do like a mutation analysis, DNA analysis, and over time you'll want to get audiologic testing and skin cultures for the increased risk of infections. The pathology here is noted acanthosis and papillomatosis, more basket weave hyperkeratosis, more follicular plugging. Eccrine glands may be diminished in number and atrophic as well. The key here is the associated symptoms associated with KID, and it's in the name. It makes it super helpful. All right, on to palmar plantar keratodermas, or diffuse PPK. And this has a diffuse bilateral symmetric hyperkeratosis of the palms and soles with a white to yellow hue, well demarked keratoerythematous borders, nose transgradients, secondary painful fissuring, sometimes dermatophytosis in areas of scale, associated hyperhidrosis plus or minus bromhidrosis may be noted. You might have some keratotic lesions of the dorsal surface of the hands, feet, knees, elbows, and volar wrists in the Unathos variant. And that is because, we'll talk about that here in a second, it's based on the mutation. But in addition, treatments here, you'll have your classic treatments: topical emollients, keratolytics, oral retinoids, topical and oral antifungals, Some reports of Bath puva have been used, which is pretty interesting. Um, Inheritance here, autosomal dominant fashion, and depending on the subtype is the keratin gene most likely involved. So the Warner subtype has keratin genes 9 or keratin 9 involved most likely, where the Unathos is keratin 1 involvement. Now, Warner is keratin 9, 9 being maybe worse if you were like to do like a 1 through 10 scale. So that's the one that's going to more likely have epidermolytic hyperkeratosis in the pathology, where the Unathos variant being keratin 1 is not likely to. It's not characterized by epidermolytic hyperkeratosis on path. And you can also remember Unathost being number 1 because Uno sounds like Uno if you don't know Spanish. So Uno Thost, keratin 1 gene. These subtypes of PPKs are the most inherited PPKs. The mutation ultimately, is respective to its own keratin. So keratin 1 is retained throughout all the skin's upper layers of the skin, starting at the spinosum but climbing higher. And that's why in the Unathos variant you might see those other isolated plaques on various other surfaces. However, keratin 9 is mostly expressed only in the palms and sole upper layers. So then that's why the Warner variant you might have less involvement generally and more focal involvement in the palms and soles. Ultimately, prenatal diagnosis can be found through DNA linkage analysis, just DNA mutation analysis in general. And we talked about the histologically characterized by focal epidermolytic hyperkeratosis, specifically in the Warner variant. Next, we have Howell-Evans syndrome, and that's considered a focal PPK in the weight-bearing areas. The key here is that when you find this in the young age, this diffuse like plantar, palmar, keratoderma, you should be on the lookout for an increased risk of esophageal carcinoma. And how do I remember that? I remember that because howling, requires your throat to do howling. And the esophagus is also in your general anatomy of throat. So that's how I remember that you can't howl if you have esophageal carcinoma. Other associated features with Howell-Evans syndrome includes keratosis pilaris, dry skin generally, and oral leukokeratosis or leukoplakia. Treatment here, the classic treatment, except you need to do the added evaluation of the oral cavity for the leukoplakia and the esophageal the esophagus for the esophageal carcinoma periodically. Inheritance here is an autosomal dominant mutation in the TOC gene. Incidence here is rare. Mutations in the TOC gene ultimately affect proteasome function. The key here is just making sure that you're able to link this with esophageal carcinoma. That is the key. Moving on, we got von Winkel syndrome. Another way you might see this is under the name mutilating PPK. So don't be alarmed if you see two names for this. So mutilating PPK is also known as von Winkel syndrome. This presents with a diffuse honeycomb PPK, and the interesting thing that you don't typically see anywhere else is this digital constriction of the fingers, most commonly the pinky, the 5th digit, and that's pictured here on the bottom left. Other things you'll see is associated features such as starfish keratosis on the knuckles, scarring alopecia, and potentially a progressive hearing loss. Treatment here, topical therapy, oral retinoids. You need to release that band or there's going to be auto amputation of that pinky. And then cochlear implants are considered too. The mutations in GJB2, which back to another connexin encoding discussion here. You'll have a normal prognosis, if you catch the hearing disability, if that progresses and you're able to cochlear implant them, or if they want to choose being deaf. That might be the only thing that hampers their living. The other thing is you want to catch the pinky, make sure that doesn't auto-amputate, but once you get past those things, it's a relatively normal life. Here on the left, you're going to see some of those starfish keratoses on the knuckles as well. Malde-Meleda, and excuse me if I'm pronouncing any of these wrong, I'm trying my best. Malde-Meleda though here is a palmar plantar erythema with scaling and thickening. It's a keratoderma. It's got well-defined borders and transgradients, so that means it will progress beyond. It will continuously progress beyond the palmar area. Um, Associated features here, you'll have painful fissures. This one has a malodor, so mild amyloidia has a malodor. Hyperhidrosis kind of plays along with the um, malodor as well. The constriction of the bands of the distal phalanges, not quite as strongly associated as mutilating PPK, but still present. You can have subungual hyperkeratosis and colonychia. Treatments here again: keratolytics, oral retinoids, surgical release of constriction bands if you have them. This is a mutation specifically in the SLRP1 gene. So you slurp on your island a bad or mal drink. So that's kind of how I put some things together. Bad, the drink could be bad because it smells bad. The drink could be bad because it's chalky. I don't know what you want to do after that, but that's kind of what I do. How I put things together. Slurp a bad drink on the island of mild amyloidia. Rare disease here. Most cases actually originate from this island in the Adriatic Sea, and the mutation here in the SLRP1 gene encodes cell signaling and adhesion proteins. The prognosis is normal, otherwise not concerning. Just make sure we get control of those constricting bands if they're present. Oh, and this picture here, this is a good example of transgradients here because you're seeing it's not on the plantar aspects purely. It's actually evolving to involve in a continuous fashion the dorsal surface of the feet as well. Alrighty. Alright, let's keep going. We got Papillon Lefevre syndrome. Presentation: somewhere between birth and 5 years old, you're going to start noticing this. It is also a palmar plantar keratoderma with erythematous borders and transgradients. This can involve the Achilles tendons as well. It's a diffuse PPK, more commonly. The association, so the P in papillion also goes with the P in periodontitis. So there's going to be premature teeth loss. And if you're not using that calcium in your teeth, you must be using that calcium elsewhere. So you're putting that calcium in the dura. So you're going to have dural calcifications as well at the tentorium and the choroid attachments. Moreover, you could have pyogenic infections or a higher predisposition, and hair may be more sparse than previously. The key here is to make sure they have great oral following and treatment, as well as your traditional oral retinoids, topical keratolytics, and potential antibiotics if needed. The mutation here is in the CTSC gene. It's a rare disease. The CTSC gene encodes for cathepsin C. Cathepsin C is a part of the lysosomal protease pathway, so that ultimately is a deficit in that pathway. Resolution of periodontitis after all the teeth are shed, unfortunately. Mandible and maxillary distortion may result because you have this premature tooth loss, and that helps shape the mouth. But prognosis, just note that you might have, as a result of the periodontitis, you might have all your teeth that are gone, and that can influence how your mandible and maxilla have shaped, because you need the pressure from your teeth to continue molding those bones. Otherwise, look out for those calcification findings in the brain, and be on the alert that there could be increased risks of bacterial skin infections, as well as meticulous dental work and dental treatment following. All right, we have Richner-Hanhart syndrome. This disease presents in infancy with severe keratitis of the eyes with photophobia. There's corneal ulcerations and neovascularization that can happen with this, blindness as well. In addition to the eye symptoms, you're going to have a focal or diffuse PPK. There may be pain with it. You might have erosions, bullae, and erythema, but all this kind of varies. This happens beyond infancy. It's more of a childhood disease. So usually the eye symptoms come first. Other associated features include hyperkeratotic plaques on the elbows and knees, and there may possibly be mental slowness here. Treatment, and we'll talk about it when we go over the gene and everything with that, but the treatment here is low phenylalanine diet, low tyrosine diet, topical therapy, oral retinoids, and they absolutely need to follow with an ophthalmologist. Inheritance here is autosomal recessive in the T18 gene. The T18 gene breaks down the tyrosine pathway, and that leads to accumulation of biochemical products that are, in a sense, toxic to both the CNS, the eyes, and in this case, the skin as well. Very few cases reported, but still important. If you do dietary intervention, you can probably get away pretty easily, avoiding or reducing your skin and ocular complications. But the key is just getting rapid evaluation, rapid diagnosis, and being able to identify that as the cause. You can do that through prenatal amniocentesis. You can do that through DNA analysis. You can do that through slit lamp exam and seeing dendritic keratitis, as well as elevated serum and urinary levels of tyrosine. Alrighty, now we're going to talk about derriere disease here. The presentation can happen anywhere from 6 to 20, maybe even a little older, and it presents as a punctate PPK with warty plaques. You'll have seborrhea as well. So that means, beyond the PPK, you can have trunk, face, scalp flexures, and groin involvement. You'll have keratotic papules. They vary in color, and that's okay. They can easily be super infected, whether it's through viral or bacterial means. Other things you'll see also on the left pictured here is longitudinal bands on the nails, subungual hyperkeratosis, some V-shaped nicking of the nails, cobblestone papules on oral and anal genital mucosa. Rarely some mental findings as well, including schizophrenia and mental retardation. Treatment here for derrieres is systemic isotretinoin, systemic acitretin. Both can be used. You can try topicals. You can limit sun exposure. You want to make sure that you cover your superinfection. And if there is a concern for, mental challenges, then a psychiatrist referral as well. The mutation here is in the ATP2A2 gene. Now, it's autosomal dominant as well. Now, what's important about that is you'll often be asked to compare this with Haley-Haley, right? And Haley-Haley is a mutation in the ATP2C1 gene. Now, for Haley-Haley, I think of, how I want to see a comet one day, and there's Halley's Comet, right? So that's 2C1 comet. ATP2C1, and then just by process of elimination, ATP2A2, it would be derriese. ATP2A2 is a gene that encodes for SERCA2, and that is a calcium pump that ultimately becomes defect, and this mutation is in the smooth endoplasmic reticulum. The other comparison is Haley-Haley's is more in the Golgi. So those are some things, just kind of some highlighting high yield things to kind of keep organized in your head if you don't already know them. DDX here includes Haley-Haley, like we talked about, Grover's, which has overlap, PRP, psoriasis. You will note on the biopsy here that you're going to have histologic findings of hyperkeratosis, corp bronze, and acantholysis. Now, the key difference here between derriese and Haley-Haley's is derriese, being the D, will have more dyskeratosis, so that's your corp bronze, etc. And Haley-Haley will have more acantholysis, if you had to separate between them, because these diseases overlap significantly on path. Even though they present differently on physical exam, overlap on path. All right, next we're going to talk about, and I think last, is epidermal nevus syndrome. So epidermal nevus syndrome, specifically the syndrome itself, is the manifestation of epidermal nevi in association with other developmental abnormalities. Now, you can have epidermal nevi by themselves, and they're benign. But in this case, you have epidermal nevi in the combination of maybe a CNS or MSK abnormality. So CNS abnormalities, you'll see mental retardation, seizure, spastic hemiparesis, sensory neural deafness, cerebral hemangiomas, vascular malformations. And these are associated with, how many nevi do I have, or how extensive, or where are they located? Are they located on the head and neck? Additionally, you can have skeletal findings, such as hemihypertrophy, kyphoscoliosis, ankle and foot deformities, rickets-like presentation, and this is also associated with the location of skin nevi. Other ones are noted here too, like skin hemangiomas, capillary malformations, etc. And treatment-wise, you can treat some of these. I mean, you can ablate them or try to remove surgically the lesions. Obviously, that won't treat the associated features, but For even more hyperkeratotic lesions, you can consider CO2 laser or topical keratolytics if they're incredibly hyperkeratotic and extensive. Oral retinoids might be helpful. But the key here is getting them to the places they need to be, and that includes neurologists, ophthalmologists, and orthopedic referrals. We don't have exactly the inheritance pinned down yet. We do know this is kind of rarely reported, and lifespan might be limited. There's malignancy potential with these patients. There's those cerebral vascular malformations, which can cause hemorrhage and seizures, and those are concerning. Ultimately, you could have epidermal nevi and be fine. That's why that's on a differential. But in these rare cases where there's association, you're not. And back to what we talked about with epidermolytic hyperkeratosis or epidermolytic ichthyosis, you want to do a skin biopsy of an epidermal nevus because you want to rule out features of EHK. And when you rule out features of EHK, then you can reassure that you're not going to pass down EHK. So remember what I said, if you have an epidermal nevus and you biopsy it and you see features of EHK, epidermolytic hyperkeratosis, then you want to warn the parent or consult them to let them know there is a chance that if you have offspring that you're a mosaic for an EHK-based mutation and you may pass it on. That's something that they need to know. Additionally, you want to do EEG for the seizure activity, potentially consider some sort of brain imaging to evaluate for vascular abnormalities that might be in the brain. Skeletal survey, depending on the severity or the concern of, rickets or hemihypertrophy, as well as serum and calcium, phosphorus level monitoring. And with that, we will finish up this lecture series. So let us know if you have any questions, if there's anything that you saw, anything you want to correct, anything you want to add, please do it down in the comments below. If you have a good way to, remember some of these things, like you have a good tip you want to share, please let us know. That's the way we kind of learn and get through this together. Beyond that, any questions, any comments, any concerns, throw them downstairs. If you like this video, give it a like. Give a shout out to the med students to help me put this together, and we'll see you in the coming videos.